Should we start?
Sure, sir.
Yeah, we are live on YouTube. We'll start in a minute, right? Yeah, good evening, everybody. Welcome to this evening episode of Pursue, and we have Pursue 4F, which is gynae pathology, and we are streaming live from Tata Medical Center, Kolkata. And we have a very important topic and a very special person to talk on that topic. And the topic is something which bothers everybody in general practice and also in special areas of activity in ovarian tumors. The topic of the day is borderline ovarian neoplasm, how to tide over the confusion. And to sort out this confusion, we have Dr. Divya Mehta, who is an MBBS MD pathology with a PDF in oncopathology from Tata Medical Center. She's a senior consultant in Department of Oncopathology, a very well-known name in India in gynae and uropathology, and she is right now in Tata Medical Center, Kolkata, India, with multiple international and national publications. She is one of the very well-known people who handle all the gynae path areas. Before I ask Madam to take over, let me request you to keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Divya, ma'am, please share your screen and start. Thank you so much. Just press present now, your entire screen, and press in the center and share. Yeah, we can see your screen. You just make it full screen, please.
Yes, sir. 1 second, sir.
You just press that arrow, yeah, it will go there.
Second.
Doesn't matter. No, just share your presentation from the bottom, yeah. Just share it first, make it full screen first, and then come back to that.
It's working well now. Full screen. 1 second, sir. This icon is coming. You're presenting to everyone.
Just press that arrow there, the corner arrow, yeah. Just press it, yeah. It's
now, can you see it, sir?
Yeah, I can see your full screen. Just press the hide. Pop up, yeah.
Right, done.
Fine. Please start. Thank you.
A very good evening, sir, and a very good evening to all our online viewers. Sir, at first, I would like to thank you for making me a part of this Pursue series and giving me this opportunity to share with you this talk on ovarian borderline tumors with specific, regard to the 2020 WHO classification. And I will be very happy to discuss some evolving concepts and diagnostic criteria. So coming to the word borderline as per the Webster's dictionary means being in an intermediate position or state. It also means it's not fully classifiable as one thing or its opposite. It also means it's not quite up to it. It's not typical of. It's not as severe as. Basically, it's neither here nor it's there. In today's concept, we can, current conditions, we can say, okay, the COVID vaccine, how efficacious is it? Someone says borderline, it's going to cause some confusion, isn't it? So with the same, regard to ovarian tumors, when we say borderline ovarian tumors, it does give rise to confusion, and I'll tell you why it gives rise to confusion. First, the term borderline itself, but I hope this topic of mine, and as I proceed, I will be able to tide over this confusion, and you will be able to understand the diagnostic criteria, as well as understand the challenges that we face in the diagnosis of borderline ovarian tumors. So coming to the introduction, borderline ovarian tumors are neoplasms of epithelial origin characterized by upregulated cellular proliferation. Now there's an upregulated cellular proliferation, means it's not benign, right? There's the presence of slight nuclear atypia, it's generally mild to moderate, even that's not benign, but without stromal invasion, which means it's not malignant. So it's neither there nor here, it's somewhere in the middle and it's borderline. And the fact that it is somewhere in the middle was first described by Taylor in 1929 when he called it semi-malignant. That means it was neither benign nor malignant, so chalo, let us use the term semi-malignant. FIGO 1971, WHO 1973 said, okay, let us call it tumors of low malignant potential. And let us distinguish them from ovarian cancers, which have obvious malignant potential. Further refined by the WHO 2014, who used the term borderline tumors for the first time, and they used it interchangeably with a term called atypical proliferative tumor. Okay. Now coming to the blue book, but a light blue book, which is now there, that is a WHO 2020, which tells us that you should just call it borderline tumor. And they say it's not recommended to use the term atypical proliferative tumor for reasons. They say that once you're calling it borderline, you're going to stage the disease. There's going to be a staging surgery, okay? Because this borderline tumor has propensity to, spread to the peritoneum. It can even cause some lymph node lesions. So you're going to stage the disease. So it's not right to call it just atypical, all right? It's a very atypical, does not give it a very serious connotation. Then they said, okay, you may have problems with staging it. This may evolve to a carcinoma. So let's call it borderline. And there are a few cases, as I said, which can evolve into pelvic or extra pelvic or peritoneal disease. So let's not call it atypical or low malignant potential. Let's call it borderline. So the current WHO 2020 guidelines tell us that they should be called borderline ovarian tumors. They say it's not recommended to use the terms atypical proliferative tumor, which was used in the WHO 2014, and the further other terms, the older terms, tumors of low malignant potential, it should not be called that, and don't please call it non-invasive low-grade tumor. So just the term borderline ovarian tumor. Now, borderline ovarian tumors are of 6 histological subtypes. The serous borderline tumors being more common than mucinous borderline tumors. Serous borderline tumors worldwide, they comprise 50% of the borderline tumors. Mucinous borderline comprise 45%. But in Asia, it's a bit different, where mucinous borderline tumors are more common, sometimes even up to 70%. And then you have the uncommon 4 endometrioid borderline tumors, clear cell borderline tumors, seromucinous borderline tumors, and borderline Brenner's tumors. This uncommon 4 is what I'm going to speak about a little less towards the end, and I'm going to spend most of my time today speaking about serous borderline tumors and mucinous borderline tumors. So now coming to the confusion. Why the confusion with regards to borderline ovarian tumors? Now, it's a borderline tumor, but it can be associated with microinvasion. They can harbor an intraepithelial carcinoma. There can even be lymph node involvement with borderline ovarian tumors, and they can cause extra ovarian disease in the pelvis or in the peritoneum in the form of implants, and these implants are by definition non-invasive implants. We'll talk about implants a bit later. So there are so many things associated with this borderline business: microinvasion, intraepithelial carcinoma, lymph node involvement, and peritoneal disease or pelvic disease in the form of non-invasive peritoneal implants. And therefore, establishing the correct diagnosis can be very challenging in these cases, okay? Then, of course, I spoke to you about the uncommon histological subtypes, the endometrioid borderline tumors, the clear cell borderline tumors, the seromucinous, and the borderline Brenner. They are uncommon, and therefore the diagnostic criteria for them are less well defined, more so because we don't see them that often. And also, their diagnosis is hampered by subjectivity, and hence more confusion. All right. Now, there's another interesting thing, that sometimes the distinction between benign and borderline can be difficult, okay? But it's important. Why do you need to distinguish a benign cyst adenoma from a borderline tumor? The reason is, if you're calling it borderline, it's got clinical implications. It means the patient will undergo a staging surgery. For example, if you have a borderline ovarian tumor, the ovarian tumor will be taken out, the omentum will be taken out, peritoneal biopsies will be taken. If it's a mucinous borderline, an appendix will be taken out. So this implies a staging surgery. And there will also be a follow-up protocol. So it's very important that you distinguish your benign from borderline. Do not overcall your benigns into borderlines and subject a patient to unnecessary staging and unnecessary worry and follow-up. So that is why there is this confusion, and I hope this talk will try to put the confusion to rest. All right. First, coming to serous borderline tumors, and that's because it's quite very common, 50% worldwide. So these are non-invasive, again, non-invasive, low-grade, proliferative serous epithelial neoplasm. So they're not benign because they are proliferated. They comprise 50 to 55% of borderline ovarian tumors. There's a wide age group with a median age of 50 years, and they have symptoms attributable to an ovarian mass. Their pathogenesis is that they are associated with KRAS and BRAF mutations in around 30% each, and usually in a mutually exclusive fashion. Now, molecular analysis have demonstrated that these serous borderline tumors harbor similar molecular and genetic alterations as low-grade serous carcinomas, that is KRAS and BRAF, and in some cases, you can see a continuous tumor progression. You can see a serous cyst adenoma and a borderline ovarian tumor and a low-grade serous carcinoma all in the same specimen. Okay, so that's about the pathogenesis. Grossly, these tumors are measured around more than 5 centimeters in size. 1/3 are bilateral, which means that 2/3 are unilateral. They are unilocular or multilocular cystic tumors. But one important thing I want you to pay attention to is that grossly, they can have a predominant intracystic component whereby the papillary excrescences are in the inner wall of the cyst, or it could be an exophytic component where the papillae are there on the surface, or it could be a combination of both. So I'm sure you're used to seeing some of these gross specimens in the lab. This is an example of a serous borderline tumor which is entirely intracystic. So this is within the cyst. This is arising from within the cyst wall. This is exuberant polypoid and papillary tumor protruding from the interior of the cyst wall. So I want you to remember this. Then I want you to remember that they also can have a predominant exophytic component. So this, as you can see, is the ovarian surface, and here is a unilateral tumor, okay, with prominent surface exophytic component composed of this broad papillae and papillary excrescences. Also, there are some subserosal, some serosal tumor implants here and some over here, but you can see the difference. An intracystic component over here predominant, and over here you have an exophytic component. You can have a combination of both. I want you to keep this in mind. Now coming to the microscopy of serous borderline tumors, these are tumors with formation of papillae with a hierarchical branching pattern. By hierarchical, we mean it follows a hierarchy from the king to the minister to the subject, something like that. From the topmost to, it becomes a large papilla, then a smaller papilla, and then finally tufting. There is a hierarchy to this branching. So that's the first one. Second, it is a borderline tumor, so it's going to have some epithelial stratification and tufting. So the tufting is actually the last component of the hierarchical branching pattern. So, and then it's got nuclear enlargement with mild to moderate atypia. So remember, this is borderline. So it's going to have atypia, which is going to be from mild to moderate. Now, if you want to make a diagnosis of serous borderline tumors, all these three features, that is the hierarchical branching pattern papillae, the stratification, and the mild to moderate nuclear atypia should be present in 10% or more of your total tumor area. Okay, and there should be no microinvasion. To call it SBT, it should be, if you want to call it SBT per se, there should be no invasion. There should be no, the peritoneal implants, if present, should be of the non-invasive type, which means if you have extra ovarian disease in the pelvis or in the peritoneum, it should be of the non-invasive type. And I will tell you what invasive, non-invasive means in a bit. And there should be no destructive invasion in the form of a desmoplasia and small nests going into the stroma. None of this should be present. So let us look at a picture and see what I'm saying. So you have the papillae here, these broader papillae. Can you see them? They are of a hierarchical type, a big papilla branching to a smaller, and then there is tufts. Okay, they are lined by proliferating epithelial cells, and if you see the underlying stroma, there is no invasion. So this is a serous borderline tumor. Now I wanted to show you the nuclear changes. So this is a typical serous lining of a serous cyst adenoma of a benign tumor. Look at it. It's got a pseudostratified columnar epithelium, very bland looking cells with cilia over here. Now compare this with a borderline on this side. There is definite nuclear atypia. It's mild to moderate. There is no severe anisonucleosis. How do you know that there is no severe anisonucleosis? This nucleus is similar to this nucleus, is similar to this nucleus, is similar to this nucleus. So there is no severe change. It's not that one is very small, one is very big. That's not happening over here. It's mild to moderate nuclear atypia. There are some small nucleoli. All that's allowed in a serous borderline tumor. And here it's forming some tufts, and there is this eosinophilic cytoplasm. So this is the nuclear features of a serous borderline tumor. Now, I'm not going to spend time on immunohistochemistry because that's not very important when we are diagnosing a serous borderline tumor. Morphology is more important. They are Pax8 positive because it's of Mullerian origin. They are WT1 positive like all serous neoplasms. They express ER and PR, and they are P53 wild by immunohistochemistry staining. That's because they do not harbor P53 mutations. The high-grade serous carcinomas do. That's a different line altogether. I'm not getting into that. We are concentrating on borderline tumors. FIT positive, WT1 positive, ERPR variably positive, and P53 IHCs of the wild type. Now, the first confusion. What if those changes are 1, 2, and 3? Hierarchical branching papillae, stratification, mild to moderate nuclear atypia is present in less than 10% of the total tumor area. What are you going to call it now? Now, if you have an intracystic tumor, remember the word intracystic that I told you? That means your outer surface is smooth, the inner part of your cyst wall has those papillary projections. If those papillary projections in an intracystic situation is less than 10% of the total tumor area on microscopy, then you can call it a serous cyst adenoma with focal epithelial proliferation, which means it's benign. You don't need to extra follow it up or worry about it too much. It won't recur. So that's the thing. But if you have sampled it well, okay? So if these changes are present in less than 10% of the total tumor area, that is SBT-like changes. In an intracystic situation, you can call it serous adenoma or serous adenofibroma, whatever the case it may be, with focal epithelial proliferation. You needn't call it serous borderline tumor. Now, the WHO specifies this definition only in an intracystic situation. They do not talk about what happens if it's there on the surface. But studies have shown that if you have a tumor, a papillary SBT on the surface, but the proliferation is less than 10% on the surface, it's better to call it an SBT, because if it's on the surface, it has a propensity to go to your extra ovarian sites, travel as implants onto your peritoneum, your pelvic nodes, to the pelvic structures, into the lymph nodes, etc. So that is why it's important that that you keep this thing in mind, that SBT-like changes less than 10% of the total tumor area for an intracystic tumor, you can call it serous cystadenoma or cystadenofibroma with focal epithelial proliferation. Think of it as a benign tumor and forget about it. But if you have it on the surface of a tumor, these changes, but less than 10%, I think there should be a comment in your report saying, please note it's less than 10%, but it's on the surface. This may recur. Better call it a serous borderline tumor, irrespective of that 10% cutoff. Okay. So this is just a picture to show you a cystadenophibroma. Okay, this is cystadenophibroma, serous cystadenophibroma, a low power. Now something's happening over here, something's happening over here, and you can see that whatever is happening over here, the proliferation is less than 10%. So in this area, okay, and if this is an intracystic area, then and it's showing these kind of changes of hierarchical branching papillae, nuclear atypia, stratification, but less than 10% in an intracystic situation, you will call it a serous cyst adenofibroma with focal epithelial proliferation. But you will not call it with focal epithelial proliferation if this less than 10% is on the surface. The 10% cutoff does not hold good for an exophytic tumor because it has propensity to spread to the peritoneum in the form of implants. Okay. Now, next term. So it's a serous borderline tumor. But what is this thing called serous borderline tumor with microinvasion? So this is a term where you have an invasion which measures less than 5 millimeter in greatest dimension in any single focus and consists of small cell clusters or individual cells with abundant dense eosinophilic cytoplasm or small papillae within clear spaces which are cytologically similar to your SBT. Basically, good-looking cells looking like SBT, small clusters, individual cells, small papillae lying within empty spaces, measuring less than 5 millimeter in greatest dimension in any single focus. Suppose they're in multiple areas also, doesn't matter. In any single focus, if it's less than 5, you will call it SBT with microinvasion. And mind you, this focus of microinvasion has to be cytologically looking like SBT. And the prognosis is that it has not negatively affected the outcome. It will behave like a serous borderline tumor in a good way itself. All right. So this is your serous borderline tumor over here. And this is the area of microinvasion. It should be less than 5 millimeter to call it microinvasion. There should be small clusters of eosinophilic epithelial cells over here. Look here, with a psammoma body lying within this non-vascular space and measuring less than 5 millimeter and looking similar to the SBT over here. This is serous borderline tumor with microinvasion. Now, what is this term microinvasive low-grade serous carcinoma? Is this same as serous borderline tumor with microinvasion? No, it's not. This is basically crowded medium-sized papillae in clear spaces which look like low-grade serous carcinoma adjacent to an area of SBT and measuring less than 5 millimeter. So if I'm confusing you, I'm not doing it deliberately, but this is what it is. If you have a less than 5 millimeter focus of crowded and medium-sized papillae, but looking like low-grade serous carcinoma, slightly more atypical than your SBT, looking different from your SBT, then it is possibly a micro-invasive low-grade serous carcinoma. Please sample that tumor more because you will find larger foci of invasion of low-grade serous carcinoma. You most likely will find a larger focus of invasion of low-grade serous carcinoma, and this will behave like a low-grade serous carcinoma. It's not going to behave like a serous borderline tumor. All right. So this is the kind of focus. If you get, less than 5 millimeter of it, of these larger crowded papillae, looking like your low-grade serous carcinoma within these clear spaces next to an SBT, and it measures less than 5 millimeter, you are going to call it micro-invasive low-grade serous carcinoma, and you will sample the tumor more to look for more areas of invasion and establish a diagnosis of full-fledged low-grade serous carcinoma. Okay, now coming to the next confusion. What is this serous borderline tumor of the micropapillary or the cribriform type. Now, the word micropapillary means elongated papillae without any stromal cores, which are more than 5 times the length to the width ratio, and they are slender, they do not have a core. Cribriform means punched out spaces. So the micropapillae can sometimes fuse together and form cribriform or punched out spaces. So you have a serous borderline tumor composed of this type, micropapillary or cribriform subtype. Okay, so these micropapillae are elongated structures without a stromal core, which are 5 times more than 5 times the length to the width ratio, and they directly come out from a larger papillae like a medusa head appearance. I'll show you a picture. Or the micropapillae could fuse and form cribriform spaces. When you get this kind of micropapillae or cribriform spaces more than 5 millimeter in one dimension in your SBT, you have to take note of it and you have to call it an SBT of the micropapillary of the cribriform subtype, because these are associated with advanced stage disease and recurrences and warrant closer follow-ups. Okay, now these micropapillary or cribriform areas should have a higher NC ratio than your SBT generally, but they are not that high grade. Okay, and the mitosis are there, say around 2 to 3 or 3 to 5, but they are not more than 12. Basically, what I'm trying to say to you is you need to distinguish this micropapillary or cribriform structures from a high-grade serous carcinoma. Okay, so look at this. This is what I was talking to you about. Your SBT serous borderline tumor can have areas like this, where you have these elongated papillae without a stromal core directly coming out from this larger papillae like a medusa head. Okay, and if this area is 5 or more than 5 millimeter, you'll call it SBT of the micropapillary subtype. This is what your micropapillary subtype, this is how your nuclei look like. Look at this diagram over here. They look like they more or less, there is not much anisonucleosis. This nucleus is similar to this one, to this one, to this one. Mitosis is not frequent here. Contrast this to this high-grade serous carcinoma where every nucleus is different from the other. Look at this atypical mitosis. So it should not look very high-grade. That's the deal. It should look like mild to moderate atypia again with few mitotic figures. And if you have this micropapillary area, 5 or more than 5 millimeter area dimension in any area of an SBT, you need to note it and you have to call it SBT of the micropapillary subtype. And as I said, sometimes these micropapillae fuse and form cribriform structures. And if this cribriform area again is 5 or more than 5 millimeter in an SBT, you call it SBT of the cribriform subtype, micropapillary / cribriform subtype, because it warrants they have an aggressive disease. All right. All right. So this is what I was trying to show you. This is the micropapillary area, if you can see, and over here you measure it with your ruler, and if it is 5 or more than 5 millimeter, you call it the micropapillary subtype. And this is over here showing you this epithelial papillae. These are the papillary structures, these ones. And they are slender and long, and they are coming out from a single large papillae like a medusa head. And their length is 5 times that of their width over here. This is the width of the papilla. The length is 5 times that of the width. Okay. All right. Now we finished with the micropapillary cribriform subtype. Let us talk about implants. As I told you right in the beginning, approximately 30 to 47% of patients with SBT, that is serous borderline tumors, develop extra ovarian disease. Extra ovarian means they have propensity to go out of the ovary into the pelvis or into your peritoneum in the form of tumor implants. Now, if your tumor, your serous borderline tumor, has an exophytic component, I discussed exophytic exophytic component with you, then it's a strong marker of extra ovarian peritoneal disease, which means if you have an exophytic component, you have surface involvement of your ovary by a serous borderline tumor, more chances that you're going to have extra ovarian disease in your pelvis, in the peritoneum, etc. Okay. Now these peritoneal implants, how are they classified? They are classified as non-invasive and invasive. But SBT, that is serous borderline tumors, by definition form non-invasive implants. If you have invasive implants, it is not serous borderline tumor, it's a low-grade serous carcinoma. So how do you distinguish between non-invasive and invasive implants? Now, traditionally, non-invasive implants SBT implants are by definition non-invasive. So if you're talking about implants, only the non-invasive implants should be ideally called implants, because invasive implants should be called low-grade serous carcinoma. Okay, so non-invasive implants can be of two types: the epithelial type and desmoplastic type. Basically, you just have to remember they are non-invasive. By non-invasive, what do we mean? I'm going to show you. So non-invasive epithelial implants means there are papillae with mild cytological atypia without much stroma or inflammation around them. And non-invasive desmoplastic implant means there's a lot of stroma, there are fewer glands, and that those glands are, kind of entrapped in that granulation tissue like stroma and an inflammatory infiltrate. So the difference between these two is that the non-invasive epithelial implant has epithelia and no stroma. The desmoplastic implant has more stroma and less epithelium, but both are non-invasive. By non-invasive, we mean they are just tacked onto the peritoneal surface. They are just like tacked on, they're just stitched onto the peritoneal surface, okay? And non-invasive epithelial implants have an excellent prognosis with an overall survival of 95.3%. So let me show you examples from these photomicrographs. This is an example of a non-invasive epithelial implant. This is the peritoneal surface over here. This is the interface between the implant and the fat. If you see, they are just stitched onto the fat, like it's just kind of looks like as if it's just sitting on it, okay? And it's got this epithelium over here, and it's got this psammoma bodies over here. They're just stitched onto this. This is a non-invasive epithelial implant, all right? This again is a non-invasive epithelial implant over here. It's just stitched on. This is an example of a desmoplastic implant. Here there is a little bit of epithelium and a lot of stroma around it, okay? But even this, it feels as if you can remove them from the top of the peritoneal surface. Now, invasive implants are, the presence of it implies low-grade serous carcinoma, and they should actually not be called invasive implants. It should be directly designated as low-grade serous carcinoma. What are they? They are micropapillary structures or nests of epithelial cells with retraction artifacts set in a densely fibrotic stroma. They cause destructive tissue invasion, and the epithelial component predominates. There's so much of epithelium that you feel from your section that we can't take it out. All right, which means they are invasive implants. And this is the most important adverse prognostic factor. So look at it, so much of epithelium in between the fat, destroying that fat over here, going in between. This is an invasive implant and therefore implies low-grade serous carcinoma. Non-invasive implants are like this. They are stitched onto the surface, sitting very innocuously, and they can just be removed from that, okay? So this is the concept of invasive and non-invasive. This is another micropapillary pattern. This fits into an invasive implant. And again, clusters of cells in empty spaces which are devoid of epithelial lining in between these fat lobules is again an invasive implant. Now, just to show you through a diagram, this is an invasive implant. Look at the implant. There's blue structures all in between the fat, destroying the fat, and you feel when you sit in your slide, you cannot take them out. But look at this non-invasive implant sitting very nicely on top of the peritoneal surface. You feel that you can just pluck it out from the surface. So this is a non-invasive implant. So an invasive implant implies low-grade serous carcinoma. Non-invasive implant implies serous borderline tumors, and serous borderline tumors by definition have non-invasive implants. If you find that they are causing invasive implants, then you have to classify this as a low-grade serous carcinoma. Okay, now coming to the next confusion. We are calling these tumors borderline tumors and they are causing lymph node involvement. Oh my God. But this lymph node involvement occurs in the subcapsular sinuses rather than in the parenchyma. They are said to be arising from endosalpingiosis. Endosalpingiosis means, foci of fallopian tube-like epithelium in extra fallopian sites, means not in the fallopian tube but in other sites. You can have just like endometriosis. So you have tubal-like epithelium in the lymph nodes as endosalpingiosis, and it says that these lymph node involvement actually arises from there rather than through actual hematogenous spread. Okay, and that's why they're more in the subcapsular sinuses. They are single cells, papillary clusters, or glandular structures, and they resemble non-invasive epithelial implants. The presence of lymph node involvement in a serous borderline tumor does not imply an adverse prognostic factor. It is not equivalent to a metastatic carcinoma, but you have to stage it like an N1 disease. So when you apply your TNM staging, if you have a lymph node involved by serous borderline tumor, you will have to say that it's involved by serous borderline tumor and therefore it's N1 disease, but it does not mean the same thing as that of a metastatic carcinoma. Okay, so this is an example of this implant, non-invasive implant-looking structure in the subcapsular sinuses of an abdominopelvic lymph node in case of a serous borderline tumor. So you will have to stage it as N1, but it does not mean that it's metastatic. So in the end, there's this confusion which everyone has. I've got a diagnosis of a serous borderline tumor. It's got implants, it's got lymph nodes. Shall I stage it or not? Or is the FIGO staging or the TNM staging only for carcinomas? You have to stage serous borderline tumors by the TNM or by the FIGO staging so that one knows the extent of the disease. Okay? And this is the FIGO staging, where stage 1 means tumor confined to the ovaries, stage 2 means tumor going to the pelvic sites, to the pelvic extension, which means it can involve pelvic organs like the uterus or the fallopian tubes, or it can involve the pelvic peritoneum. FIGO stage 3 means tumor has gone beyond the pelvis into the peritoneum, again in the form of non-invasive implants, or it has involved retroperitoneal lymph nodes. And stage 4 means it has gone even to distant organs, that is the lung, etc. Okay, the pleural effusions. So the prognosis of SBT. Patients with FIGO stage 1, which means limited to the ovaries, show no significant difference in the overall survival compared with the general population. So if it's limited to the ovaries, they do very well. But women with advanced stage have a little reduced survival. And there is a 4 to 7% patients with SBT who develop low-grade serous carcinoma. And the risk factors for development of low-grade serous carcinoma are the micropapillary or the cribriform subtype, which I discussed, an advanced stage when it causes non-invasive implants in the peritoneum, bilaterality of the tumors, as I said, ovarian surface involvement, and if after surgery you leave disease behind, that is residual disease after surgery, it implies a risk factor for the development of low-grade serous carcinoma. Now, coming quickly to mucinous borderline tumors, as I said, they comprise 30 to 35% of borderline ovarian tumors, but they are more common in Asia, where they can contribute to around 70% of borderline ovarian tumors. They are complex, non-invasive mucinous neoplasm with a GI type of differentiation. They also have a median age of presentation of around 45 years, and their pathogenesis is that they arise from a cystadenoma and are associated with KRAS mutations in 30 to 75% and can be associated with a Brenner's tumor and a dermoid cyst. Now, you all have seen a mucinous borderline tumor in the lab. They are quite large as compared to a serous borderline tumor. They are unilateral in general. They have a smooth ovarian surface and they're congested vessels on the surface. Now, serous borderline tumors can have an surface involvement with, as I said, exophytic. But no, not for a mucinous borderlines generally. They are cystic with a smooth ovarian surface with congested vessels. Once you cut them, they have multiloculated with smooth walls and a mucinous content. Now, there may be solid areas, and you need to sample this very carefully to rule out an invasive component and to look for mural nodules. I'll talk about mural nodules shortly. So the general rule is if your tumor is less than 10 centimeter, 1 section per centimeter, and if your tumor is more than 10 centimeters, 2 sections per centimeter of the tumor. Okay, so this is your typical mucinous borderline tumor, which is a large multicystic tumor. Look at the outer surface is generally smooth, and there are these variable size cysts filled with viscous or gelatinous mucin. On microscopy, they are lined by columnar mucinous epithelium of the GI differentiation. They are borderline, so they show epithelial stratification, tufting, papillae, mild to moderate nuclear atypia. There is some mitosis more in the crypts and less prominent on the luminal surface. I'm going to go a little fast with this because I think you got the hang of serous borderline tumors. We'll follow some similar principles for mucinous borderline tumors. So at least 10% of the epithelial volume must show this increased proliferation. Okay, so if you have MBT-like areas, that is, papillary formation, epithelial stratification, and mild to moderate nuclear atypia in at least 10%, you can call it a mucinous borderline tumor. So this is a typical mucinous cyst adenoma. There are these cysts which are lined by these flattened, by these columnar cells with these basal nuclei. Okay, so columnar cells, basal nuclei, very bland looking and abundant luminal mucin here. So this is your typical mucinous cyst adenoma. This is your mucinous borderline tumor. Look at the difference. There are some glandular and papillary structures. They are lined by GI-like epithelium, and you can see at this power also there is some they're not all basal. There is some proliferation, pseudostratification. Let's go to higher power. This is an area of a benign tumor, a cyst adenoma, and this is lying right next to it, a borderline area. Look at this. Columnar epithelium, totally basal nuclei. And over here, there is nuclear pseudostratification with mild, in this case, actually looking like mild nuclear atypia. So, another area showing this nuclear changes in a mucinous borderline tumor. Look at the stratification of the nuclei. They are at various levels and not basally located. And look at the mild to moderate nuclear atypia. So the confusion, what if the epithelial proliferation is less than 10% of the epithelial volume? Now there's no concept of exophytic in this. Okay, so there is, that the tumor has an outer surface is smooth. So if you have a mucinous cyst adenoma with less than 10% of these changes, proliferation, papillae, nuclear atypia, you will just call it mucinous cyst adenoma with focal epithelial proliferation. This is as benign as it can get. There's nothing to worry about this tumor. Okay, so this is an example of a mucinous cyst adenoma. This is a cyst adenoma, this is a cyst adenoma, and look at this over here. Less than 10% is showing these papillae with stratification. So this is a mucinous cyst adenofibroma with focal epithelial proliferation. Now, I told you about the nuclear atypia over here, and I said it's mild to moderate. Okay, nothing more. What if the nuclear atypia is severe? Now, if the nuclear atypia is severe and it's focal and patchy, you can call this a mucinous borderline tumor with intraepithelial carcinoma, and this is seen in 40 to 55% of mucinous borderline tumors. And the prognosis says that there is no difference in the overall survival in cases of MBT with or without intraepithelial carcinoma. Now, mind you, I said focal or patchy severe nuclear atypia. If you get diffuse nuclear atypia, every gland is showing severe nuclear atypia, not mild to moderate. Please consider, can this be a mucinous carcinoma? Am I undercalling this by calling it borderline tumor or with intraepithelial? Is this a primary mucinous carcinoma, or is it a metastatic mucinous carcinoma coming from somewhere? So, intraepithelial carcinoma, the changes are generally focal or patchy. They are not generally diffuse. Okay, so this is one concept you need to keep in mind, and this is the changes. Look at your borderline areas over here and look at the nuclear atypia. It's much more than moderate, it's quite severe nuclear atypia. This is an example of an intraepithelial carcinoma. So this is benign, this is borderline, and this is severe nuclear atypia but no invasion. So this is an intraepithelial carcinoma, and it's focal and patchy. It's not there here, it's there over here a little bit. So this is an intraepithelial mucinous borderline tumor with intraepithelial carcinoma. Again, the concept of microinvasion. So MBT with microinvasion means you have single cells or clusters or small foci of back-to-back glands, but less than 5 millimeter. Remember, the nuclear atypia is the same as a borderline tumor. It's not very severe. If it is less than 5 millimeter, you call it mucinous borderline tumor with microinvasion. So this is an example of a mucinous borderline tumor, and if it is less than 5 millimeter, this particular area of invasion, and the nuclear changes are similar to that of the borderline area on top, you can call it mucinous borderline tumor with microinvasion. Now, what is microinvasive mucinous carcinoma? So if this area of microinvasion has severe cytological atypia, it is a microinvasive mucinous carcinoma, and you again have to sample it extensively to look for frank areas of invasion. And this, however, this particular diagnosis has limited data on tumor recurrences. So just for a diagrammatic representation, this is your mucinous borderline tumor, and this microinvasive component has severe nuclear atypia. Look at this. This is bland. This is severe. This is a microinvasive mucinous carcinoma. Over here, you have a mucinous borderline tumor, and this is the invasion component, less than 5 millimeter. But the nuclear features are similar to the overlying borderline tumor. This is a mucinous borderline tumor with microinvasion. This does very well. This may cause recurrences, and you have to sample this extensively to look out for real areas of invasion to call it a mucinous carcinoma. So this is your microinvasive mucinous carcinoma. This is your borderline area. Next to it, there are very bad nuclei infiltrating the stroma. This is your microinvasive mucinous carcinoma. I discussed with you the concept of mural nodules, and I said that there are some nodules within the cyst wall of mucinous neoplasm. You can have such nodules. These nodules can be made up of sarcoma-like reactive spindle cells. They could be made up of frank sarcoma-like cells. They could be foci of anaplastic carcinoma within these mural nodules, or it could be a mixture of all this. These nodules, which can occur in the cyst wall of mucinous tumors, can vary in size from a couple of centimeters to 10 centimeters. They can vary in number also. Prognostically, the mural nodules, which are composed of anaplastic carcinoma, exhibit aggressive behavior, and you need to know about this entity. So this is an example of a mucinous carcinoma, and I'll tell you why this is a carcinoma in a short bit. And this is this area over here, which is looking quite busy. This is an example of a mural nodule in the wall of a mucinous carcinoma. And this is made up of very anaplastic looking mitotically active cells, which were cytokeratin positive. So there is a mural nodule of an anaplastic carcinoma in the wall of a mucinous carcinoma or a mucinous borderline tumor. This implies a very bad prognosis. However, you may also have areas of, pseudosarcoma looking areas, like granulation tissue like areas with inflammatory cells, histiocytes, bland spindle cells. You can have a mural nodule made up of this also, but they can mimic a sarcoma or an anaplastic carcinoma, but they're not mitotically active. They are not very angry looking cells. This does not imply a very bad prognosis. So not only you have to sample the solid areas to look for mural nodules, you have to see how these mural nodules look under the microscope. And remember, the anaplastic carcinoma ones have the worst prognosis, and these pseudosarcoma ones do not have a bad prognosis at all. Now, how do you differentiate a mucinous borderline tumor from a mucinous carcinoma? Now, mucinous carcinoma has two patterns of invasion. It can have a confluent pattern of invasion, or it can have a destructive pattern of invasion. A confluent pattern of invasion is sometimes very difficult to distinguish from a mucinous borderline tumor, and that's where the confusion lies. Basically, the expansile pattern means you have back-to-back glands with no stroma in the middle, giving you a complex labyrinthine appearance. Okay, the degree of nuclear atypia in this expansile type mucinous carcinoma is quite similar to a mucinous borderline tumor, and hence you may get confused. Is this a mucinous borderline tumor or is this a mucinous carcinoma with an expansile pattern? The confusion lies because there is no stromal desmoplasia. But remember, back-to-back glands more than 5 millimeter implies mucinous carcinoma of the confluent or the expansile type, which has a very good prognosis. So this is your mucinous carcinoma, back-to-back glands just stuck to each other in a very complex way with no stroma in the middle, leading to a very labyrinthine pattern more than 5 millimeter. 1, 2, 3, 4, 5, 6. This is 6 millimeter. This is an invasive mucinous carcinoma of the expansile or the confluent type, which has a very good prognosis. Now, not a confusion. If you have an infiltrative pattern of tumor cells infiltrating into the stroma with desmoplasia, you generally do not there's no difficulty in differentiating this from a mucinous borderline tumor. So this is how it looks, a very destructive form of infiltration arising from, and this is a borderline area maybe, and this is not a very difficult thing to distinguish from a borderline tumor. Now, another very big problem, and actually this is the problem I'm most scared of. I'm not very scared of serious borderline tumors. I am scared of this particular thing, which is sometimes a mucinous borderline tumor can mimic a metastatic mucinous tumor. So metastasis from the GI tract, for especially the appendix, the mucinous colon tumors, endocervical tumors, pancreatic mucinous tumors, they can go to the ovary as a metastasis, but they look borderline under the microscope. So that's a very, very scary situation because you need to differentiate primary versus metastasis because it is significant for prognosis and therapy, and I'll tell you why. And immunohistochemistry can be of limited help in this particular situation. So how would you know that this is a primary mucinous tumor versus a metastatic mucinous tumor? You can use this particular algorithm. Now remember, primary mucinous tumors are uncommon compared to metastasis. So metastasis of mucinous tumors is more common than primary mucinous tumors. If you have a primary mucinous tumor, you need to do surgical staging and you have to debulk the tumor. If you have a metastatic mucinous tumor, it's already metastatic. You don't need this elaborate staging surgery. Primary mucinous tumors are unilateral and they have a large size. Metastatic mucinous tumors are bilateral and they are smaller, the cutoff being 10 to 12 centimeters. Primary mucinous tumors generally do not have surface involvement. They have a smooth surface, whereas surface involvement is present for metastatic mucinous tumors. Primary mucinous tumors will present to you at stage 1, only limited to the ovary, whereas metastatic mucinous tumors present to you with an advanced stage. Primary mucinous tumors do not have dissecting pools of mucin in between them. They can have some of these glands can rupture with some mucin around them, but they don't have dissecting pools of mucin leading to pseudomyxoma, peritoneae and ovary, except when mucinous tumors arise in association with teratoma. This part you need to remember. Whereas metastatic mucinous tumors coming from the appendix, etc., can cause pseudomyxoma, peritoneae and pseudomyxoma ovary. Additional microscopic features: LVI is not seen in primary mucinous tumors, signet ring cells are not seen, hilar involvement is absent, whereas metastatic tumors present a lot of tumor emboli. Signet ring cells, when you see, you know this is not a primary mucinous tumor, it's probably coming from the stomach, and hilar involvement is seen in metastatic mucinous tumors. Now, when I'm dealing with a mucinous tumor, the immunos that I would like to do, even if it is a mucinous borderline tumor, remember, because tumors from the endocervix and the pancreas and the appendix can mimic a mucinous borderline tumor. So the immunos that I like to use are CK7 and CK20. Ovarian tumors are CK7 positive and CK20 also positive, but CK7 is more than CK20. Ovarian mucinous tumors are SATB2 negative. They express this marker called SMAD4 or DPC4, which is actually lost in pancreatic, 50% of pancreatic tumors. These tumors do not show, ovarian mucinous tumors do not show strong P16. They express PAX8 in 50%, not in all cases, and they are ERPR, mostly they are negative. Now, if I had to rule out an appendiceal tumor, they are CK20 positive, 7 negative. They express SATB2. If I wanted to rule out a pancreatic or biliary primary, they are CK7 positive and 20 positive, and they show loss of SMAD4 in 50% of the cases, and they don't express Paxate. Endocervical tumors can sometimes mimic, not sometimes, many times mimic mucinous borderline tumor. The P16 immunostain can be used because the P16 immunostain in the HPV associated endocervical tumor is strong and diffuse block positive, whereas it's very focal or patchy in a primary ovarian tumor. Okay. So the last part about mucinous tumors associated with teratoma, remember, normally mucinous borderline tumors do not have abundant dissecting mucin in the stroma, but if they are associated with the teratoma, you can have mucin extravasation in the ovarian stroma and in the peritoneum, causing pseudomyxoma peritoni or pseudomyxoma ovari. Another thing, some of these teratomas, they have lower GI epithelium because there's a teratoma, it can have any kind of epithelium. You can get GI type tumors arising from these teratomas, which will be CK20 positive, 7 negative, SATB2 positive, just like your lower GI tumor, but the primary is actually in the ovary. So be careful of mucinous tumors associated with teratomas. This is an example of an ovarian mucinous tumor over here, and there's a teratoma over here, and it's got pseudomyxoma ovari, lots of mucin in the ovary and the peritoneum. Okay. Now coming to the other uncommon borderline ovarian tumors, I'll just spend 5 minutes on this if I'm permitted. The endometrioid borderline tumors are very rare. They're associated with endometriosis, and there are two patterns, an adenofibromatous pattern and an intracystic pattern. Okay, an adenofibromatous pattern is like this, where you have endometrioid glandular proliferations embedded in a fibroblastic stroma. They look like atypical hyperplasia of the endometrium. There's a lot of stroma in the middle. This is an endometrioid borderline tumor of the adenofibromatous type. They're not crowded back to back. There's a lot of stroma in the middle. Over here you can see some central squamous area. Or you have an intracystic pattern where you have simple papillae protruding into an endometriotic cyst, something like this. You have an endometriotic cyst with these protrusions of these endometrioid glands. Now, these are very rare actually, and the criteria to call them microinvasion, etc., is not very well defined. These tumors, you'll have to rule out a GI primary and an endocervical primary when you see them. These are Paxate positive, ERPR positive, therefore you rule out a GI primary. They lack block positivity for P16, therefore you rule out an endocervical primary. Now coming to a clear cell borderline tumor, again very rare to exist alone as clear cell borderline. They normally exist along with a clear cell carcinoma, and they look like this: focal crowded nests and glands with clear cells showing low-grade nucleotypia in a fibromatous stroma. The typical tubulocystic papillary pattern should not be seen to call it a clear cell borderline tumor. If you see a tubulocystic pattern or if you see crowded papillae pattern, then it is to be called a clear cell carcinoma. But remember, clear cell borderline tumors do not exist alone as borderline. They are normally associated with a clear cell carcinoma. Again, they are Paxate positive, HNF1 positive, napsin positive, negative for ERPR and WT1. This concept of seromucinous borderline tumor. What is the seromucinous borderline tumor? Basically, it used to be called the endocervical mucinous borderline tumor in the past. They are also associated with endometriosis and are very similar to endometrioid borderline tumors. Okay, they look like this: broad papillae with stromal edema, and they have an endocervical type of lining with inflammatory cells. They may have serous areas, squamoid areas. So they have very different areas looking like multiple Mullerian epithelia. They need to be distinguished because they are Paxate positive, 7 positive, 20 positive, CDX2 negative, ERPR positive. So if you know that they are Paxate positive and ERPR positive, you automatically rule out a GI primary. And this expression is very similar to an endometrioid tumor. The last one is the borderline Brenner's tumor, extremely rare. It's a tumor of transitional or urothelial-like epithelium, which displays a papillary architecture but lacks stromal invasion. It's got an excellent behavior, and look at this papillary and polypoidal areas, looking like your low-grade papillary urothelial carcinoma, but no stromal invasion. These are Paxate negative. They express the urothelial markers like P63 and GATA3. They are negative for ERPR and WT1, and they show loss of staining for P16. Now, the overall prognosis of borderline ovarian tumors is that the vast majority are limited to the ovaries, and 75% are diagnosed at FIGO stage 1, that is limited to the ovaries. Compare them to ovarian carcinomas, where only 10% are diagnosed at an early stage. They have an excellent prognosis and a 10-year survival of 97% for all stages combined, but they can recur and they can undergo malignant transformation. That is why they are put in the borderline category. Now, how would you treat them? They are borderline, they are not benign. So you need a complete surgical resection, and in addition, you need to do a full surgical staging, including omentectomy, peritoneal biopsies, cytology of the peritoneal washings, and you need to take out the appendix in case of a mucinous borderline tumor, because you want to make sure that it's not an appendix going into the ovary and mimicking a mucinous borderline tumor. And I discussed the IHC to distinguish between an appendiceal primary and a primary ovarian tumor. And remember, these are borderline tumors. Adjuvant chemotherapy is not indicated. So you must know the exact criteria to call something borderline. You should not overcall it and you should not undercall it. Overcall means you're calling some benign borderline, which means you're subjecting it to staging, you are subjecting it to a very strict follow-up. If you're undercalling it, you are denying, and it's actually a carcinoma and you're calling it borderline, you're actually denying it further treatment like adjuvant chemotherapy, which may be indicated in the malignant tumors. So it is very essential to know to establish the correct diagnosis, because these cases can be challenging, and then you will be able to manage them well. So the take-home points are that the subtypes of borderline ovarian tumors, they are all distinct biologically, pathogenetically, molecularly, and you can't put them under a single unifying concept of a borderline ovarian tumor. They're all different. The borderline malignant potential is best validated for SBT, for the serous borderline tumors. The diagnostic criteria has been established. It was established in the WHO 2014, further established in the current WHO 2020. Challenges remain, as I told you. The distinction of mucinous borderline from expansile mucinous carcinoma is challenging. I find it very challenging sometimes. Also, a MET of a mucinous appendiceal mimicking a mucinous borderline, again, use IHCs and it can be very challenging. Differentiation of SBT with microinvasion versus SBT with very small foci of low-grade serous carcinoma, it can be very challenging. And to categorize implants as invasive and non-invasive can be very challenging, because invasive implant means you're calling it low-grade serous carcinoma. Non-invasive implant means you're sticking to your diagnosis of serous borderline tumors. So at the end of it, I don't know how confused you are. If you are, I hope you're not overreacting, because you have the WHO 2020 with you. Refer whenever there is a difficult case. The more you see, the more you learn. With that, I would like to end my presentation, and I hope I was audible throughout.
Yeah. Absolutely audible, very nice, very explicit, very clear, wonderful.
Thank you, sir.
And very nicely done. The topic is very confusing.
Thank you, sir.
Definitely, you have shown us the light and the way out. And we are very, very appreciative of what it is. So there are some questions on the YouTube. Would you like to take them?
Sure, sir.
Right. So there is the first question is from Dr. Minish Gandhi. He says, how to differentiate low-grade appendiceal mucinous neoplasm from BOT mucinous from morphological grounds alone? Like, yeah.
So, mucinous, the low-grade appendiceal mucinous neoplasms, they generally have pools of dissecting mucin. They are associated with pseudomyxoma peritonitis. So, your clinical features also should give you a clue. They also have these retraction clefts around them, morphologically. They have these retraction clefts around these glands, which can help you. The pools of dissecting mucin can help you. For mucinous borderline tumors, they generally don't have pools of mucin. They can be ruptured with some mucin extravasating, but you don't have dissecting pools of mucin. You don't have pseudomyxoma peritoni. If you have pseudomyxoma peritoni, pseudomyxoma ovari, it is not of ovarian origin unless it is in association with a teratoma. The only caveat being, if it's arising from a teratoma, only then. Otherwise, it is arising from somewhere else. And the most common culprit is the appendix, and that is why they do an appendicectomy at the time of doing a staging surgery. And immunohistochemistry can be very helpful. CK7, CK20, I think most of you have. If you do a CK7 and a CK20 in an ovarian mucinous borderline tumor, there's more 7 than 20. In appendiceal neoplasm, it's 20 positive and 7 negative. We now have SATP2. We've started using SATP2 very, very often now, particularly with these tumors. Mucinous borderline tumors are SATP2 negative, whereas appendiceal mucinous tumors are SATP2 positive. So that helps. Now, PAX8 is iffy marker because in mucinous borderline tumors, it is positive in a very focal way, around 50% or less of the cases. So it may help you, it may not help you, but the overall clinical picture, the pseudomyxoma, the dissecting pools of mucin, and those retraction clefts I've noticed can help. Yeah. And they mimic, sometimes they may not be, those mucin pools, and they just look like a mucinous borderline tumor, and you'll be amazed that it's 20 positive and 7 negative. So I always use these markers, 7 and 20, always, for even borderline mucinous tumors. And believe me, for me, this is the most challenging part. I always get scared when I get a mucinous borderline tumor. It's not easy. I hope I've answered that.
Yeah, you have, and you have answered that so confidently and so correctly. And is another question by Dr. Minesh Gandhi, and it's more of a discussion than a question. He says, in our experience, we find mucinous borderline tumor uncommon compared to malignant ones. So what's your take on this?
That's the second part, sir?
No, you finish this off because it's the two.
So mucinous borderlines are not that common, as I said earlier. Also, they are not that common. The metastasis, which is more common. So I always worry if you're overcalling it. So you always rule out a metastasis when you're dealing with a mucinous borderline or a mucinous carcinoma. Also, make sure it's not a metastasis. And many things can help you, right from your clinical to your gross, to your cut section, then your intraoperative findings, and of course your morphology. All these things can help you, and in the end, of course, immunohistochemistry can come to your rescue. Yeah.
Yeah, you're absolutely correct, absolutely right, spot on. Now, the second part of it is it necessary to rule out mucinous LAMN appendix before signing out BOT mucinous?
Oh yeah, absolutely, yeah, absolutely.
Yeah. I also agree with that. And there is another thing which I would like to say before I go to the next question is that, there is a lot of inter-observer variation, which one needs to keep in mind, in trying to analyze these things in its totality. So there's nothing called a straight line. And the second part of the question, the second question, by Dr. Bhagat Singh Lali, that's a very important question. How to differentiate desmoplastic non-invasive implants from invasion?
Okay, very good question. Bhagat's my fellow, and I'm glad he asked that question. So, non-invasive desmoplastic. So, firstly, it means that there is a lot of stroma and there are very few glands, okay? And they are tacked onto the surface, as I said, Bhagat. They are on the surface of the peritoneum. Less epithelium, more stroma, okay, and they are on the surface of the epithelium and they are stitched on. You feel when you see them on the slide that if I take my finger, I can just take it out. That's what I do many times. I just see, can I take it out from the slide? You can actually take it out from the slide. Now, for a invasive implant, massive desmoplasia, lots of epithelium and they are all over the fat. They're not stitched on. You can't, if you just put it under your slide, and this is something I learned from Dr. Malpika when I was one of her lectures, and she said when you put it under the slide and you try to remove them from the slide, from the omentum, you can't take it out. So that is your invasive implant. Okay, destructive invasion, lots of epithelia, extensive desmoplasia, too many glands. Whereas non-invasive desmoplastic implants, very few epithelia and a very granulation tissue-like atmosphere around it. So that's your non-invasive desmoplastic implant. Non-invasive desmoplastic implant equals to serous borderline tumor. Invasive implant ideally should not be cause implant at all, is equal to low-grade serous carcinoma.
Right. Correct. Yeah, I agree with that. Absolutely correct. Yeah, I would like you to understand that there is about a half a minute delay in transmission from Google Meet to YouTube. So we just have to give them some time
Sure, sir.
to address to that reply before they may come with another question or any more clarification. In the meantime, if anybody in the Google Meet would like to ask any question, they can either type here or they can unmute their mic and ask directly to the expert. Okay, just wait a minute, please. If just please. Actually, I'm trying to coordinate between all the three, aspects: the live show, the Google Meet, as well as the YouTube, simultaneously on three screens simultaneously.
Did a great job, sir.
Bhagat says, "Thank you, ma'am." That's the answer.
Thank you so much, sir. Thank you. Thank you for having me here.
Before I close this session, let me thank you, Dr. Divya. Wonderful presentation. The confidence was superb. You really made us proud. I mean, I'm so happy to have you here and to talk on such a wonderful topic in such a nice way. You're really an expert in ovarian tumors, that I can understand. And thank you everybody for joining in. Wonderful show. Thank you so much. God bless you, Dr. Divya. Thank you so much.
We'll definitely have you more. Thank you, sir. Thank you so much, sir.
We will surely have you more and more time here. Please take out time for us.
Sure, sir. Sure, sir.
Yeah. Take care. Bye-bye. Good night.
Bye-bye, sir. Good night. Bye-bye. Thank you, all of you.
Please share the PDF of this lecture so that we can share it with the students, right?
Sure, sir. I will do that. I will.
Thank you. Bye-bye.
Thank you, sir. Bye-bye, sir. Bye. Good night.